Hi, well, Mike Gibson and Ajay Kirtane coming to you live from TCT with our daily wrap-up. Probably the highlight today, I guess, was Bill O'Neill coming in through the back door, through the venous system to do a valve replacement. Tell us about that.
Yeah, Bill's been a proponent of this, the transcaval technique for transcatheter aortic valve replacement, and basically for folks with severe peripheral vascular disease who don't have arterial access and you don't want to go transapically because that's a mini surgical procedure.
Sure.
He's been going through the vein and then essentially finding the aorta and going from the IVC into the aorta, and then putting the sheath across, doing the TAVR that way, and then sealing the hole at the end with the ductal occluder device. And he did this live today in one of the arenas. And so clearly that's something that was a lot of people were talking about afterwards. He's published on this, in fact, and
Yes.
it's something that for extreme situations it may be useful, but nonetheless it's something very innovative, obviously.
Yeah, interesting. What else was hot in the live cases?
Well, we started the main arena with a complex CTO. There were also valve cases as well. Today was a kind of a big valve day as a whole, with data not only on the partner trial presented, but CoreValve had some data, and also the use of embolic protection filter device as well.
Yes.
Essentially, for me, and I'm sure you thought the same, Mike, with the partner data, 5 years demonstrating continued superiority of the valve versus standard therapy was impressive, especially finding that essentially only one patient randomized to standard therapy in that trial who did not get some sort of valve was alive at 5 years.
Amazing,
I mean,
amazing number. One person.
Only one person in the whole trial.
Surviving without this procedure, versus how many with the procedure?
Well, so that's the thing, is on the other hand, about 70% of patients, even with the procedure, were actually dead at 5 years.
Right.
So I think that emphasizes what a high-risk patient population this was.
But still 30% are alive.
And especially when you think about it over time, especially with long-term follow-up of trials, you often see convergence of the survival curves because people are just dying from everything else.
Sure.
Here, there was continued separation. So I think especially for lower risk patients, this is now going to really show you, this trial is not going to get done again.
Right.
And it's going to show you that this therapy actually can really improve survival for these types of patients and keeping people out of the hospital.
And it's never going to get done again because the control arm is never going to get done again. Only one person survived. So that control arm becomes very, very important as an anchor for all these other trials.
Absolutely.
So then we saw the 2-year partner data today using that kind of medical therapy arm as the control arm. Some pretty positive results there as well.
Yeah, I mean, the CoreValve investigators couldn't even randomize simply because at the time partner came out, then it was unethical to randomize to a control arm like that. And so the 2-year data from CoreValve is what I think most people would find very consistent with what they expected. Great rates of adverse events relative to what was thought to be the control, which was the benchmark set by partner. Can't compare the two directly because they're different patient populations, but clearly we have 2 good valves here currently in the United States for commercial use and a whole host of others on the way.
And when you look at the landmark data, 1 year to 2 years, really obviously no additional bleeding signal. Interestingly, the pacer signal seemed to be combined to a periprocedural problem. So, it looks like some of those early complications did not continue out from 1 year to 2 years.
Yeah, I think just based on the device and the way it sits in the ventricle, that isn't going to be an early complication that's going to occur if it occurs. Can be dealt with at that time without many sequelae, and that's what happens. Certainly the other complication that we worry about is stroke, and that's why the Clean TAVI study came out with the Claret filter. And this was a secondary endpoint study, not clinical endpoints, just simply looking at diffusion-weighted MRI and whether or not this filter could reduce MRI hits, and it certainly appeared to do so. We need to sort of await the results of the US IDE trial, the Sentinel trial, to see if this can be replicated in a larger series of patients. But if it does, remember, this is a thing we worried about a lot with transcatheter aortic valve replacement, whether we could cause strokes. And if there's a way to prevent it and do so safely, then that might be something that we tend to use in a lot of patients.
Which brings me to the other, I think, interesting finding today from the 2-year follow-up in the CoreValve experience is the quality of life issue. I mean, these people come in and 95% of them are in class 3 or 4 heart failure. After the procedure, 95% are in class 1 or 2 heart failure, and that quality of life seemed to be preserved out at 2 years. So as I always say, not only are we adding years to these people's lives, but we're also adding life to these people's years as well. I mean, who wants to do one of these procedures and have patients who all have strokes? But I thought that was very encouraging as well.
Yeah, I think so. I mean, there's still going to be some selection that we have to use. We have to be a little bit judicious in it. There are some patients that, may be so sick for whom, even if we do this, we may cure the aortic stenosis, but not the comorbidities. And so things like aggressive dementia and otherwise, that's not going to help us. But with both these data in hand, core valve as well as the 5-year partner data, it becomes pretty compelling. Now, the cost issues are something we have to address as a society. But when you're faced with an individual patient in front of you that has a reasonable quality of life and is interactive, as a physician, it's going to be very, very hard to say, no, we don't want to do this because it's too costly.
Sure, sure. And then ISAR closure, the world still is very much a ephemeral world. 4,500 patients, 2 devices versus a manual hold. Quicker achievement of hemostasis with the closure device, but otherwise no difference in complications.
Yeah, I think the main thing is it's tough to know what to make of the study because it was primarily diagnostic angiography.
Yeah, correct,
and most
not
of the
PCI.
bleeding complications and sheath complications occur with bigger sheaths with antithrombotic therapy on board. That having been said, I think for those that believe in closure devices, this sort of is somewhat reassuring because there are some studies showing maybe an increased incidence of complications, but not entirely clear how to extrapolate the study of the United States because neither of these devices, or at least one of the devices is not commonly used, and the other one is not even available here in the United States. I've gone over to radial, so for me, that's the appropriate way. But when it comes to vascular closure, I think the key things for everybody is make sure you do an angiogram, make sure you do the stick very assiduously, and then if you're going to use a device, use meticulous technique when you do so.
Anything hot tomorrow?
Well, I think the big news for tomorrow will be Absorb 2, which is the first randomized trial of a bioabsorbable scaffold that'll be presented in the morning by Patrick Sorois. So that's what we're looking forward to. And then Monday is a pharma day, so it'll be fun for sure.
It'll be fun. Thanks for joining me.
No, we'll do it again.
Always, yes. And thanks to all of you out there for joining us live here from TCT 2014.